the
We'll get started here in just a second and give people a couple minutes to just hop on. Morning and welcome to the June 12th meeting of the Patient Protection Commission. We're going to go ahead and get started. Chair Sexton, I'll hand it over to you.
Thanks, Dylan. Good morning, everybody. My name is Bethany Sexton. I'm the chair for the Patient Protection Commission, and let's go ahead and call the meeting to order. And Dylan, if you want to do a roll call, that would be great.
Thank you. Please identify if you're present when you hear your name called. Let's start with our voting commissioners. Dr. Jonathan Chastain. I see you're here. Dr. Khan.
Present.
Miss Marilyn Kirkpatrick.
present.
Dr. Andrea Peterson.
Here.
Dr. Adam Porth.
Here.
Dr. Travis Walker.
Here.
Bethany Sexton.
Here.
And then please mark Dr. Glyman as absent excused. Moving on to our non-voting ex officio members, Insurance Commissioner Ned Gaines.
Here.
Director Stacy Weeks, but I believe Allison Ganko-Herzik is acting.
Yes, I'm here. Thank you, Dylan.
Executive Director Janelle Davis.
Present.
Executive Officer Teresa Karsten. We'll mark her absent. Chair, that concludes roll call. We have a quorum.
Excellent. Let's move to public comment.
This item on the agenda offers an opportunity for public comment. No action may be taken upon a matter raised under the public comment period unless the matter itself has been specifically included on an agenda as an action item. To provide public comment telephonically, you may join the meeting by dialing 775-321-6111. When prompted to provide the meeting ID, enter 981-401-478#. Please press *5 to raise your hand during the public comment periods to provide your comments. Comments will be limited to 3 minutes per person. Persons making comment will be asked to begin by stating their name for the record and spelling their last name. If you wish to provide public comment and joining by phone, please press *5 to raise your hand. Joining by computer, use the raise hand icon at the top of the screen. Chair, I see no one wishing to make public comment at this time.
All right, thank you. We'll continue to move forward. Agenda item 3 would have been introduction of any new commissioners. We don't have any for today, so we will skip over that one and move on to item number 4, which is the approval and review of our meeting minutes. The meeting minutes from May were distributed to the commissioners prior to today's meeting for review. Do any commissioners have any questions about the meeting minutes or recommended edits? Seeing none, I'll call for a motion to approve the minutes.
I can make a motion to approve. This is Andrea Peterson.
Thanks, Dr. Peterson. Is there a second?
Second, Dr. Travis Walker.
Thank you. All in favor of approving them?
Aye.
Say aye.
Aye.
Anyone opposed? All right. Minutes are approved. Thank you. And then we'll move on to item number 5. And so this is the meat of our discussion today. So we're included in your materials were some of the bill draft request topics, and we'll have an opportunity to review how those were put together and some of the intent language and things here. And I'll ask Dylan, I think you're going to walk us through a little bit of that to start, and then yeah, and then we'll have some discussion.
So per NRS, the PPC is authorized to submit up to 3 bill draft requests each regular legislative session. The purpose of the discussion today is to review, discuss, and approve 3 BDRs reflecting the policy to be submitted to the Legislative Council Bureau for the 84th legislative session. After approval, staff will develop supporting materials for each of the approved BDR topics and submit to LCB ahead of the September 1st submission deadline. There are 4 BDR options that we've included in here. So what I had thought is we can go through each and have a discussion and then make a motion after that we've had those discussions on all the 3 BDRs.
Sounds good.
So to start, the first one we had was a pregnancy medical home. The measure proposed by the commission requires Nevada Medicaid to seek all necessary federal approvals to develop and establish a pregnancy medical home model to improve maternal and infant health outcomes through enhanced care coordination, integrated health services, and stronger connections to community-based supports. The model is intended to address fragmented care, improve access to timely prenatal and postpartum services, reduce disparities in preventable complications, and provide more efficient use of healthcare resources for Medicaid-covered moms and babies. And again, the language was provided to you all ahead of the meeting, but if it would be helpful, I can read through as well. Would that be helpful?
I think I read that, and if nobody else has any issues, we can proceed with the discussion then.
Agreed. I think any questions on this one, and also I'll just ask Dylan, any other, I don't think you included any other material for this particular one, correct?
No.
Okay. Any questions on this pregnancy medical home? This is one of the top ones that we reviewed last time. I think we also discussed last time trying to leave enough latitude for Medicaid and folks to come together and, you know, be able to navigate in a way that actually would work and would administratively work and other things. So I think the language accomplishes that while still, you know, putting in a lot of what we discussed, but would open the floor up to others and any other comments or thoughts on this particular one.
Yeah, this is Andrea. I'll just, sorry, I didn't put my hands up, but I would just say, I think it captured nicely, like all the discussions that we've had around this. I think it looks good.
I think one of the pieces, because we have 4 in our list, and so one of the pieces that we probably will want to have some discussion about, and we'll get there when we get to the 4th one, is around potentially combining 2 of these a little bit, and seeing if there are ways that we could pull in some of the maternity incentive payments into this piece. And so we can talk about that more when we get down to that one. But I think, at least on the face of it, this felt like a pretty solid intent. Any other concerns or questions about it, Dr. Walker?
I just had a question regarding the model that the models used to create the legislation. Was there any particular reasons why Minnesota and Texas were chosen, or were there any other states that may have been considered for this?
Other states have done it through different means. Those states have legislation that are very similar to this topic. So that's why they were chosen. The pregnancy medical home model has a lot of similarities with some of the different IHP or ACO type models that the commission discussed kind of last session. So that was why that was included as some model language.
Thank you.
Any concerns with that, Dr. Walker, or just? wanting to
Probably
kinda-
more curiosity than anything.
Okay. All right, any other dialogue on this one? Otherwise, we can keep going, and obviously we can come back to it if there are things that come up along the way. All right, so let's move to the next one.
The next item was the perinatal quality collaborative. So the intent is to improve maternal infant health outcomes, reduce preventable complications, and address variation in the quality of perinatal care across the state. Nevada must strengthen statewide collaboration and implementation of evidence-based practices. This measure intends to establish and support a statewide perinatal quality collaborative to bring together hospitals, providers, public health agencies, Medicaid, and community partners to identify improvement opportunities, implement data-driven quality initiatives, share best practices, and improve the quality, safety, and outcomes of care for mothers and infants throughout Nevada. And then again, here is the proposed BDR language that was shared with commissioners ahead of the meeting. I can read through it again, but if not needed, just let me know.
I think we'll just let everyone read it, and then again, any questions on this language? Again, I think the quality collaborative was certainly a high-ranking item. Commissioner Kirkpatrick.
Thank you. So this is pretty popular with the county, the health district. Everybody is kind of interested in it. I'm just wondering on the timeline. I don't see where there's like a timeline on when they would get going and kind of who must be on the thing, because what I would want to make sure that the people that have to execute it are part of the discussion. So it looks in number 3 that there's different organizations, but I don't see where government necessarily are they 1 seat out of 10 seats? I mean, some of that stuff matters when you start talking about putting together a board. Is there a plan? Or I think legislators would ask that, right? And so, and is there a time frame? Because what we don't want them to do is, I would think that we would want them to report back to the interim health committee, like, so that's ensuring that it gets going. Because a lot of times there's so much going on that you might lose sight of it. So, just food for thought.
Thanks for that feedback. Thoughts on that in terms of timeline and putting some added language around that?
Yeah, and just to add a little bit to item 3 there, that's kind of pulled from the MMRC establishing statute, which kind of gives the director more authority over the appointments. But they do set minimum, I think it's 6 to 12 members representing at a minimum of some different classifications. Is that something that you're more thinking?
Well, I'm just thinking that one, everybody's gonna say, oh, I want to be on that board, right?
Mhm.
So you have to either make sure that it's balanced so that people are represented from all sides, right? If you're going to move the needle. And I do think that that board should, at the very least, report to the interim health committee at least once during the interim. Just so everybody else knows what's going on, and for 2, you make sure that it gets going.
I like that ad. Any other commissioners feel like that would be a good ad to modify or put something in around that?
Yeah, this is Andrea. I would agree. I think that's a great idea.
Okay. And then,
So sorry,
Yeah.
just to be clear, the amendment would be to add an implementation date or time. And then more specific on the membership. And then adding to bullet 7, report annually to the interim HHS committee.
Well, I'm fine with not changing the makeup of the board if you just assure that there's some, that there's just some balance that stays with
Okay.
it, and really more about just making sure that it reports back to the interim committee so that we know it gets going.
Dr. Walker.
Yeah, I think kind of echoing that sentiment, just looking at kind of bullet point 3, and I think there's a lot of I think leeway in here, but it seems a little hospital centric, and thinking about kind of the rural aspect that we're trying to address, and possibly settings where, you know, we don't have hospital or birthing center involvement. I don't know if it would be helpful to be inclusive of you know, as the FQHC representative here, FQHCs, you know, different rural and health clinics. And then I don't know if it would be helpful, since we've had a lot of discussion about maternal outcomes and behavioral health, having a behavioral health representative included in there. I don't know how specific we would need to be, but just kind of going off of this, it leans more hospital heavy to me.
This is Andrea. I've had some experience with working with a perinatal quality collaborative in another state. I think I do like, Dylan, how you kind of said at a minimum. Because in my experience, as these get going and you start getting a lot of committees, you're going to want to, like, there's only going to be a lot of opportunity for participation, and then you may want to grow it much larger than you start. So it might not be a bad idea to kind of outline, like you said, did you take it from MMRC? Is that where it came from? That at a minimum, you want representation by these entities and then grow as needed.
And we can be more specific on what that at minimum means, and maybe include some of those FQHC representation or rural health clinic representation, if that is what the commission would like.
I like the idea of, I mean, I know we say including rural and frontier representation, but I think maybe calling that out specifically of like rural health clinic or whatever the right category would be there, to just be very specific about that.
You know, another, sorry, Bethany, let me
No,
raise
go
my
ahead.
hand.
No, go ahead.
So, I mean, so another thing is to think about with all these rural dollars that are coming, don't forget the tribes, right? Because the
Mhm.
tribes are some of the biggest issues that we have in the rural areas, right? So whether they just are not prepared. So I think at a minimum, you can say these people must, or you must have presentations from it, but I do think it will grow because I think it's super popular across all aspects. Just to make sure that it's not so big that you don't get anything done because 90 people can't agree, right?
Based on my review of other perinatal quality collaboratives, and Andrea, correct me if I'm wrong here, but it looks like the steering committees are typically 12 to 18 people.
I would agree. Yeah. And there will be different interests based on, you know, the initiatives that are chosen.
Mhm.
Yeah, and I would just say you've got perinatal clinical providers. My experience is it's usually like an OB, a neonatologist, a pediatrician, and a OB, perinatologist, pediatrician, and neonatologist. So at least those 4 at a minimum as far as the provider participation side.
Awesome. Okay, so we have some thoughts there around some edits, a little bit in terms of edits. Any others? See.
I'm trying to think one on the birthing facilities, like I'm trying to think, because that could make the committee like that could make it large on as far as the representation if you want every single hospital. I'm wondering if you might be able to organize like a subcommittee. Do you know what I mean? That could be comprised of all the hospitals, but they wouldn't necessarily get a seat, if that makes sense. I don't know if there's thoughts around that, but that could make it very large.
Mm-hmm. Marilyn?
So I do think that, and there's precedent setting for that, where you could, if you said this committee then has the authority to create subcommittees,
Mm.
so that then they can go do their own thing and then report back. But I do think you have to give the director or this board the authority to create subcommittees as needed, to do a
Okay.
deeper dive or something.
Yeah, and the PPC has that language in statute too, so we can take that as a model.
I think that would make sense. And then as far as like the meeting, I guess now that we're talking, at least one public meeting annually with MMRC, like, usually there's quarterly meetings. And then like the subcommittees are as needed. I don't know if you want to maybe designate that they're meeting at least quarterly so that people know when they're, wanting to volunteer, what participation looks like. And that's just the steering committee. So like the subcommittees are meeting on a more frequent basis, but the steering committee might be gathering just at least quarterly.
At least, okay.
Awesome. Great feedback, you guys. Thank you. Dr. Chastain?
I think data and the capacity to analyze it will be very important to the mission of the Quality Collaborative. And so I guess my question is, do we feel like the current language and like item number 5 set the collaborative up for success in receiving data from clinical institutions and practitioners?
Yeah, I mean, that was a question I had too, actually, when I was kind of looking at that in terms of like, does it give enough sort of authority or oomph to actually get the data and get the participation needed? And yet leaving enough leeway to not be overly prescriptive in what that looks like, because I think that group should probably define some of that. So I don't know, thoughts on that, Dylan? You might be able to.
Yeah, and
point
I'd
to
also
other
point
spots.
your attention to item 4 at the last piece of a minimum perinatal data set established. So data that isn't available to the health authority, like clinical data, they could establish a data set that they would like.
Would it be helpful to outline, and I don't know, maybe this is getting too in the weeds that we shouldn't do that, but like as far as like the collaborative would include an executive director, a data analyst. I mean, is something like that going to be helpful so that we're ensuring that they have like, a position?
Certain staffing requirements.
That would be a better way of
So
saying it.
I wouldn't do that, because I would tell you why, because then it will end up in the finance committee and never see the light of day. So regulations is like a trigger, as well as the staffing. I think that the director will already have the ability to staff it on her level, right? And we probably want to keep it that way. But I do think that maybe another add-on, which I don't want to add to the stuff, but when you're collecting all this data, then you could maybe say that the director shall keep a repository of the data, so that it all goes into one spot, so that we can actually use it to get good outcomes. Because that's the
Maintain
issue.
a data set updated annually or something to
Yeah.
that effect.
Yeah.
Because that's the issue, like when we get these grants, these peak grants or whatever at the health district or even at the county level, we go 10 months realizing, oh my gosh, we've only served 11 people. Now we've lost the grant. So if there was constant data, we might be, it'll be good for everybody, right?
Yeah, I think too, putting some like requirements around timeliness of data submissions and timeliness of data, like at least annually. I mean, that seems even long to me if you really are wanting to make impact, but Allison, I see your hand up.
Thank you, Chair Sexton. Allison Janko-Herzig, Chief of Staff for the Health Authority. Just wanted to comment, thank you, Commissioner Kirkpatrick, for mentioning the staffing and having that potentially go into the Finance Committee. I think that we have sufficient information and staffing to help support this if it were to pass. And we are asking for some additional staff in our budget through the Office of Analytics. But I think the collaborative could use information from the all payer claims database and any other data repositories we have within Office of Analytics.
Thank you. That's helpful backdrop. Dr. Walker.
I think this is more a question for my edification, but I'm trying to think through, like, we're talking about having at least one annual public meeting and at least quarterly meetings as well. And in point 5, I think it was point 5, it talks about the need to review data, but presenting de-identified aggregated data. And I don't know how this works with Nevada public meeting laws, but if there are quarterly meetings and the PQC is reviewing data that may be not de-identified, does that present a problem with either public meeting laws and reviewing this data or anything like that? I fear that de-identified, like open data may, in a public meeting, be open to scrutiny when this is really a performance improvement, quality improvement effort.
Great question.
Yeah.
I don't know if we have anybody who can help us on the line or not.
I mean, this is Gabriel Leither with the Attorney General's office, for the record. I have to say, I'm not sure I fully understand. If the issue is whether the board can discuss in the public meeting information that would contain confidential information, no, that would of course not be allowed. So you can have that information in aggregate, but it obviously can't be discussed specifically at a public meeting.
I think the question was at the quarterly closed meetings, if they could discuss that de-aggregated information. Or
is it something that would be necessary for them to perform their functions?
In theory, I would think so.
Then they probably can. We have certain closed meetings for other sessions. You may want to indicate that you can go into a closed session. We have that in other statutes, obviously, that we can go into a closed session to discuss X, Y, and Z.
That's helpful.
And that those portions will remain confidential. We do that, Dylan, for the Silver State Scripps Board.
Okay.
Thank you for that clarity.
Did I see another hand come up? Okay.
I was just gonna say what the AG's office, kind of how we can't do it through the agenda item with the closed door session. And there's a lot of latitude now from the bill that passed last session.
Thank you. Okay, any other feedback on this one? Great adds and edits there.
Hey, can I just ask one more thing? Dylan, are we going to, there's been a lot of feedbacks and some modifications, suggested modifications. When are you going to look for a motion and votes to discuss those types of things? Are you gonna do that after we discuss all 4 or do it at each
that
time?
was the.
So you're taking copious notes of some of these things?
Yes,
I know you don't need to
to
necessarily
clarify.
mention every single tiny little thing, but I want to make sure it captures most of it. I want to make sure you're
Yeah.
taking great notes.
I was just gonna ask, so these are the amendments that I have written down. So adding an implementation date must meet at least quarterly. More specific on what the steering committee will be, and making sure that it's balanced and has tribal representation as well as FQHCs and rural health clinics. And then report to the interim HHS annually, maintain a perinatal data set. And then, sorry, there was one more that I'm.
Closed door session, that they would have the opportunity to have closed door session for, review of data that may be confidential or.
Did you get this I can't remember if you need the subcommittee.
Right, subcommittee, that's
The
it.
ability to spin up subcommittees, yeah. Oh, Marilyn.
Thank you. So can I ask this question of the DAG? I don't think that that this session, open meeting law, public records request is going to be a hot topic. I think that we don't need to put in there the ability to have closed door sessions. I think, right? I think that's a trigger, right? To get people to want to hold it up. Can't they already do that as long as it's posted with the current laws that are in place? You're
Oh,
on
you're
I
on
mute
think you're on mute.
on
I saw
purpose?
that as soon as I started to talk. Thanks. You get the little pop up on my computer screen, but I've got all you guys keeping me in line too. You know, I honestly don't know the answer to that off the top of my head. I think let's have Dylan put language in there to the extent necessary. We will add it, but if it's not necessary, we won't. And then we can check and see if we already have the abilities to do it, we obviously won't add it because that would be one more reason that they might, draw interest or something to try to scuttle whatever. But if it is necessary, then we'll add it.
Okay.
Good, thank you. Were there any items that didn't hit Dylan's list that we talked about? I think that was all of them. Okay. All right, let's keep moving then, I think.
The third was perinatal service modernization. So the intent of this is to establish and support group prenatal care models within Nevada Medicaid to improve access to prenatal care, patient education, peer support, and care coordination. The goal is to improve maternal and infant health outcomes and reduce disparities. Additionally, this proposal would establish new Medicaid coverage for our dyadic care models to coordinate services for moms and babies as a connected care unit, improve access to lactation consultation services, prenatal and parenting education group programs, and establish coverage for remote patient monitoring for high-risk pregnant and postpartum persons. The language was provided to you ahead of this meeting, but I can go through it again if you would like. Otherwise, we can open up for discussion.
Any questions on this or comments?
I know you mentioned combining two, and I'm just kind of looking forward to the next one. What was the recommendation around potentially combining? I think just so I'm like thinking as I'm.
It was the perinatal payment incentive, so the enhanced rural
That's what I
reimbursement
thought.
and the incentives
Yeah.
were the
Okay.
idea of one that could be.
Would you foresee that being combined with this one? Or with the first?
It was the first. There may be an opportunity to combine it maybe with this one. But I guess that's kind of up for discussion. Marilyn.
So can I offer this? I've been talking to legislators and whatever we don't fit within our three. We do have some legislators that are willing to be champions on this issue. I'm happy to help us find homes for bills. I would hate to make 100-page bill that legislators didn't understand. It just makes for room for adding stuff that maybe we don't agree to and hijacking our bill, as opposed to finding separate legislators to, I think we need champions, right? So I have talked to at least 5 legislators that are interested in being a champion on this particular topic for, so I would, instead of making it too big, how about we just find other people that can carry the water, regardless, whatever it is.
And specifically in those discussions, have you talked about this category versus the next one, which is the payment incentives?
I've talked about prenatal care as a whole and what do we have to do within our system. So they, look at the end of the day, a lot of them are new, but it's a topic that's important. And for me, that's good enough we can educate them or whatever, but let's find homes for everything that we think is good.
Thank you for that. Dr. Peterson.
I know we'd had a lot of discussion around unbundling. So it looks like I'm not seeing that picked up in any of these. Is that something that we decided to not pursue? I see like the education D.
That's something that was indicated that we did not need a BDR to accomplish. It is included later in these slides as a potential for a formal recommendation to include in our semi-annual report.
Okay.
Great question, though, because I think we bounced around on that a little bit of whether we needed or we didn't. So we finally got some clarification there. Any questions on this one? Edits or other pieces? Dr. Walker?
I like everything that's in here. I just wonder, feasibly, is this something that, might be trying to do too much as we get this into, propose this BDR? And maybe in a sense, like going off of Commissioner Kirkpatrick, would some of these, parts better be championed? Because I can see to the point that was brought up earlier, does this become confusing because it does have quite a wide variety of services we're trying to include.
Are there any in particular that you are thinking might be best honed in on, or sort of prioritizing some of these over others?
I mean, remote patient monitoring stands out to me, and knowing that that also fits into a payment model in a lot of telehealth services that are performed. I mean, parsing that out or bringing that into the other bill, but then if we're talking about merging with another one versus trying to find another legislative champion to carry this, I don't know. I like everything. I don't want to give anything up, but I also want to realistically, make sure that this doesn't die because it tries to do too much.
And I will add it is to the extent that sufficient funding is available. So it would give Medicaid the authority to do these things within the constraints that they have.
Okay.
I also think that the reality is that just because there's a payment mechanism or a potential payment mechanism for these, the reality of them getting off the ground holistically is a stretch goal, right? So, I mean, I think that we might see one or two of these things that people are actually able to implement sooner rather than later, and that I wouldn't want to be short-sighted and say, let's not include it because it might be expensive in the long run.
So could I offer this? Maybe maybe this is a bill that we can collectively sit down with a couple different legislators, because I think that the stuff in here, some of it is specific to areas of Nevada, and you could get legislators to from across the state to maybe champion a portion, right? A number A maybe works best in Washoe County because they're already doing it. Maybe number D is something Clark County really wants to push, because then at the end of the day, if you can get all of those one-liners kind of cleanup bills to maybe get broad authority, I would write it different. I think this is too detailed for legislators. I would just say a simple line that to the extent funding is available, the administrator may amend the state plan to do anything pertinent to prenatal services and modernizing the system, right? Because then we can prioritize based on what the needs are today and based on the funding. But I think for legislators in today's environment, all of this is way too detailed, and you might find yourself where you can't implement anything because it's got too much detail and just giving the health authority the ability to, you know, amend the state plan, right? That's half of our battle because the state plan amendment takes 1.5 years to get done. And then if you didn't put it specific in, then CMS, you got to argue with them and go back and forth. How about we just give her the authority to do this regarding prenatal services? I wouldn't detail all this. I would just give her the authority to amend the plan when it comes to prenatal services.
Do you feel like there's gonna be opposition to providing that broad authority though?
No, I don't, because
Okay.
one, that department is well liked across all legislators for one. So I don't think that authority, I don't think that, I mean, that was always talked about. What is the long-term plan, right? And if you just say to be able to amend the state plan without asking for permission every time, then that doesn't hurt anybody. I don't think so. I would lobby my heart off to make sure that they had that, because we just have seen where we've lost care because we can't get through the CMS and the state plan process.
Other commissioners have thoughts on that? I mean, that's a pretty significant edit.
Yeah.
to
I was
so.
just gonna ask if Allison had an opinion on if the detail is necessary or not
Mhm.
for them to operationalize what we would like them to do.
Yeah, great question.
Yeah, this is Allison. I kind of, Gabe, I think maybe you kind of have a little bit more experience with state plan amendments and kind of the legalese of it. I think if we give ourselves, or if you give the authority, sort of this broad authority to do this, it's not necessarily a bad thing. I just want to make sure that we are very clear in what we can do, and so maybe Gabe, can you help answer some of that?
I mean, I think you're right that I think Commissioner Kirkpatrick's right that if we just have broad authority, we can go and do that process with CMS and get it done. I think we have the ability to do that.
And this is Allison again. I'll just add, I don't think that we would have an issue if you voted to give us this authority in this bill. So just want to make that very clear.
Okay, that's good.
You would have an issue, Allison, or you wouldn't?
No,
heard-
no, I would not. We would not.
Yeah.
Okay, I didn't think so, but
And then, so Marilyn, are you suggesting, I just want to be clear so that then we can have dialogue as needed with the whole of the commissioners here, that we would put a category around it and we would talk specifically about perinatal service modernization as the category or something else?
no, I would do it as the perinatal service category, because then it's anything related to modernizing the prenatal system, right?
So
I
would it be?
well, the DAG is the guy who knows best, right? But I'm just saying, we should take I think healthcare is going to be the #1 issue next session. And I think that, we could point to all of the reasons why we haven't been able to move the needle, because it's not just a state process, it's a federal process. And, I compare it to like bonding, right? We tell people to get their bonding in order a year in advance because we want you to be ready, right? So I do think that broad authority is what they should get, is my personal opinion. But I mean, you could always, if it makes people, I know you all are nervous, but you could always say, regs can establish what specifics are there, but again, why? If we just want to address this issue, just give the authority to go make the adjustments as needed.
Yeah.
Yep.
Maybe
So-
we just, I would just say, do you think we just put something around implementation of evidence-based care, like evidence-based methods for the delivery of perinatal care?
Yeah, so I guess could we take maybe #1, to the extent that sufficient funding is available, the administrator may seek state plan amendment and any necessary federal waiver authorities needed to implement for the following, or drop following perinatal services and just then specifically lay out some conditions for perinatal service modernization.
So can I ask this though, Dylan? So I know, sorry, I'm trying to just make sure. It's a complicated issue for someone that's not a champion, right? So, could you not just use this stuff as examples during the testimony as opposed to, so there's some legislative intent of what you'd like to see?
Right. I
yeah.
guess what the bill language I'm saying is to have number one and drop for the following and adding some language just for perinatal service modernization. We could offer these examples during the bill hearing, but having that as some of the more specific language.
Could we, not to also get way broader, but could we also actually put that together with the next one, which is maternity, you know, incentives or whatever as well? Like, could we make it broad enough that then both of those could sort of be inclusive in what was being done?
I mean, honestly, the pregnancy health home, like this, I don't know, like, would that just fall under this as well?
I don't want to speak for the DAG, but in my opinion, when we separated out and we created a separate agency, the intent, at least I always heard from legislators as both staff, was to give them the ability to go in and get things done, right? There are certain things within healthcare already that are somewhat exempt from different work plans and all that other stuff. But in this case, if you just give them the authority, I think you could add maternity, right? Because it's a part of prenatal care, right? So I would just give them the broad authority to address the state plan in CMS. I mean, we kind of did that with opiates, where they have express authority to go and update the plan. They have to have a couple public meetings or something. There's a whole reg process. I would give them the authority to amend the state plan whenever necessary to move healthcare. I would keep it. I like broad for a lot of reasons. So,
do you think, Dylan, that you guys need to go have a discussion? Like, do you want to maybe continue at next meeting so that you knowing that this is like a major change? What do you think?
Not necessarily. I would be concerned about adding maybe the pregnancy medical home stuff in under that broad authority, just so, because there are other components of that we would want to lay out. And I would kind of defer to Allison here on her thoughts, but yeah.
I think though we could get sufficient coverage probably for the fourth item. So do we want to just look at the fourth item real quick, and then we can come back to how we want to kind of craft what might be a more global?
Yeah. So this measure requests an increase to Medicaid reimbursement for perinatal services in rural and frontier areas to strengthen provider participation, improve access to essential healthcare services, support the sustainability of rural providers, and improve health outcomes for rural Nevadans. And the second piece is in order to improve maternal infant health outcomes and reduce preventable complications, Nevada must increase costs to and utilization of evidence-based preventative services throughout pregnancy and the postpartum period. This measure intends to establish incentives that encourage engagement in timely prenatal and postpartum care, behavioral health screening and brief intervention, and routine screening for social determinants of health. The goal is to promote early identifications of health and social needs, strengthen connection to appropriate services and supports, improve care coordination, reduce disparities, and support healthier outcomes for moms and babies. This is the language that has been proposed.
Marilyn.
Can I, so I'm wearing a different hat. So I sit on Nevada NACO. This is a hot topic with us on Medicaid reimbursement because the counties are required by statute to pay it, right? So it's typically, or to pay the match. So can I ask Allison, have we discussed this with the rural community county commissioners that are actually trying to find the money within their budget to increase these Medicaid match components?
This is Allison. Not that I'm aware of, Commissioner Kirkpatrick, but we can certainly do some follow-up and make sure that this is appropriate for them.
I listen, I would just tell you all that what you don't want is the 16 counties to be there. It's a big topic on Medicaid match right now because it comes out of their general fund. So I just think if you're going forward with this, I get it. I say it all the time from the county side. How much more of a match can I do? I'm 50% of the state's match. But it comes out of our general fund. Just understand that. So, as much as we want to help the rules, I always thought it was a scope of practice. I thought we were paying the right amount based on Medicare. I always thought it was a scope of practice on what covers. But when you say, when you increase it, you're going to get 15 counties killing it right away. To their own demise, but they, look, in the rural counties, frontier counties, they like decide how many pencils the police department gets. That's how tough it is, right? That's why this rural money coming through is such a great opportunity for them. So I just hope that we can have some real conversations with them.
That's an important call out for sure. Dr. Walker.
Yeah, I mean, I can understand that. I also see this as like an influx of funding back to those counties through the healthcare system. I think the other thing I would just need clarification on is like, how are we defining rural and frontier? Like, are we defining that at the county level, at the zip code level? Are we using, because there are definitely rural parts of Clark County when you get into Napa Valley and Mesquite and areas, Laughlin even, and the same with Washoe. And so I think that perhaps how we define rural and frontier could be important here. And I think if it's not divided by county line, I see that, there may be more support among counties that do have rural components to it. That could be served, so.
Thanks for that, Dr. Peterson.
Yeah, if you can just go back to the previous slide where it talked around like the education, the screen. I think that is kind of the beauty of doing what Commissioner, down 13, I think. Yeah, in order to improve. I think that paragraph is written really nicely. Like, it would be nice. I think that's kind of the beauty of what Commissioner Kirkpatrick is recommending with the previous one, is that it would allow you to do all of this. Because I think just kind of as far as clarification for me, is that paragraph, would it really only be for the rural and frontier areas that would be occurring? So I think.
Yeah, and I think the way we've discussed this in the past is how it complements some of the rural health transformation monies that are going out there that are aimed to improve maternal and infant health outcomes. So how can we increase the sustainability as well out there?
Yeah, I would just hate to see like this, the screen and things like that only being implemented in rural and frontier locations when that really should be universally.
Are you speaking to like the second piece here? Under three, I think is more broadly to statewide.
Okay, yeah. And I think that if we were to kind of broaden that language in the previous BDR that we discussed, it would allow the authority to be able to do that without specifically calling it out.
Agreed. That makes a lot of sense. Marilyn.
Can I ask a question of the DAG? Because I think that rural and frontier healthcare is already defined in statute, because this is why we have the rural housing, which, Laughlin, Mesquite, Logandale, Overton, all of those people do get included in that. So I thought that there was already a definition within statute of what rural healthcare is. I just would want to be consistent.
Yeah, I'm sure there's a definition of rural and frontier areas, probably of underserved as well. And so Dylan, do you know where that definition is? If not, we can just copy that definition and refer to it
I'm
later
not sure
on.
exactly where it is. I know that RHTP uses a definition of rural and frontier as well.
So we can just use those as well, right? How about underserved? Is there a definition for that? I imagine there probably is for that as well.
I'd imagine there is. I haven't come across any specific language.
So
Okay.
I would tell you the underserved definition falls under the census tract. So that it's in statute under the demographics census tract.
Thank you. Dr. Porath.
I think just to kind of build off what Dr. Peterson was saying, I'm all for like if we can minimize the language and make it inclusive, but with these particular pieces, I think I fear that if we don't specifically call out what we want to incentivize for rural, we leave that up to Medicaid's interpretation, that might not meet the commission's intent. So it just almost feels like you could have it in the same BDR, but I do think like the components of what we want to specifically incentivize for rural health probably needs to be called out.
Wondering, is there a way, and this might be a question also for Gabe. We have our report that we'll also be submitting with recommendations and things of that nature. Is there a way in the BDR to reference that report and the things that we're trying to impact as kind of the category, or is that too far afield? Do we have to be specific in the BDR itself?
No, I think you could there's probably a way that we can wordsmith that in. I'm not sure exactly how to do it right now, but if that's what you would like to accomplish, I would think that this could include references to that somehow.
Just because I'm thinking in our report, we can lay all these kinds of things out pretty specifically without getting, that it's not in the legislative language, but it's in the report of like, we want to make sure that we're impacting rural communities and helping to try to create, increased reimbursement for those services in those areas and things like that. Adam, does that maybe cover a little bit of the concern if we could do it that way?
Probably.
Marilyn?
So I was just gonna offer that last session when we did the housing stuff, we kind of like said we kind of divided, so rural areas got $9 million for the housing, the larger urban rural areas got this amount. I think you could do some language like that, which is consistent so that no matter what, because here's what I would tell you, all respectfully, I fight for the rules more than most in government, right? Because I understand what their challenges are. But at the same time, Clark County carries a heavy stick at the legislature because 42 of the 63 legislators come from Clark County. And if you cut out the Sandy Valleys, the Laughlin, and all of those people, I'm not at the table with you, right? I don't think that you could say 80% or more must be used for communities in rural and frontier counties that don't have a clinic, don't have this or that. But I mean, we've already gotten tons of pushback in Clark County because we didn't get any of the rural hospital money, right? At the end of the day. So people are mad about it. Mesquite, Laughlin, Overton, Sandy Valley, so what, we don't matter. And so I wouldn't want you guys to alienate the very people we're trying to help.
Yeah. Great point. Any other pieces on this one? And then are we ready to go back to the idea of maybe a broader, more open language that could accomplish most of these and trying to pin down what that would look like?
can I just offer one more thing, Bethany? I'm trying to,
Sure.
I don't want you guys to think I'm not trying to help the rules, but maybe there's a preamble to this type of bill that kind of references as laid out in the report. There's a preamble is a good piece to kind of set some standards, right? Or set an expectation of those. And I think within our report, you could do a preamble in the front of it. Whereas blah 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 blah, and then the bill say this. We've done some good work with rules on that to ensure that they get their fair share.
Okay, so let me, I'm gonna put forward a proposal and see what you guys think about this. So I think 1 and 2 were pretty straightforward. We can come back to those in just a minute. But on 3 and 4 with this broader, more open language, do we want to think about putting forward our recommendations to Dylan and maybe taking that back, having him take it back, do some drafting on what we have kind of put together here, and then we can save that for our next meeting, which would be July maybe, or August, if we need to have a short.
Yeah, our next
meeting.
scheduled meeting is in August, but as the chair, you are able to call a meeting.
Okay, yeah, and maybe we would have a shorter session or something like that, just focused on that language. What do you guys think about that?
I'm supportive of that. This is Andrea.
Allison, in between, can you at least get with NACO, Amy at NACO about number 3 so that, or number 4, so that they're aware that it's a topic of conversation?
Yes, absolutely. Thank you.
Okay, so Dylan, do you feel like you have notes sufficient that you could kind of read back to us on the elements that we need for 3 and 4 to be put into a wider open scenario?
Yeah, I think we'll have to look at the minutes for all of the discussion that we've had so far, but making sure that it's broad enough to capture what we have. I think my only worry is on any unintended consequences of giving that broad authority. But something to consider as we're in between meetings.
Okay, and you can run the traps on that a little bit for us, and okay.
So Dylan, could you, I do an offline, because I'm wondering what the concerns are. Because before we were, this is a crazy thing. So we used to have separate, I'm the History Channel now, sorry. They were separate a long time ago, right? Because we always knew that putting it all in one, so much stuff got lost, right? So which is why I was a big proponent of breaking it up. But we used to have broad authority. But in 2008, 2009, when we had to make cuts, we started crunching groups together. And what we found is that no good deed goes unpunished, right? So then a lot of things got lost. But in the state for many, many years, Mike Wilden is a good person for you to reach out to, because they used to have that broad authority. You didn't have to ask permission. There's a piece within statute that says many of the healthcare things are exempt from coming before because we can't wait. Tomorrow we got to solve the issue. So I would just offline be curious why you worry, and I'm glad that you do, but I just
No, I'm
think
just
that
concerned that there are things that we just haven't thought about, and I just want to make sure that we're not doing something quickly that we haven't thought about.
Yeah.
And we have
Okay.
the time. I mean, right now we actually do have the time, so I think it's a good call out, Dylan, for us to be able to take the moment and just make sure there aren't something out there. And Marilyn, appreciate that notion that, like, let's go and talk to a few people about how, maybe this had worked before, or different things like that too. That's good.
And I think such good conversation. I think that
Such-
really
such good
everybody here, I
conversation.
think, contributed in such a meaningful way to make us kind of all think like on a larger scale. So
Well, and differently. I like it. It's great. Okay, so Dylan, it sounds like you have the notes you need. Do you want to read any of them back to us just to make sure? I think you said
I'll have to go through the minutes.
the minutes. Okay,
Yeah.
we'll use the minutes as a great source. Okay, so let's go back to 1 and 2 then, if we can. roll back up to 1 and 2. And I think we had some amended edits. Or sorry, yeah, let's go to the medical home first. Okay, so I think in the dialogue that we had, we still felt like the medical home being its own thing probably would be a good piece because there's some different components that have to be put in place here. Is everybody aligned with that? I'm seeing nodding of heads. Okay. So I think now we're at the point where we can have some discussion about the idea of these three. Are we comfortable with moving these forward into BDR? And I think we'll start with just the two, and then if we're comfortable with those two, we can actually, I think, take those and approve those to move forward. And do we need to do them separately, Dylan or Gabe, each individually?
I would recommend doing them separately. This is Gabriel Leifert for the record.
Okay, thank you. So I'll open it up. Any other concerns about that? And are we wanting to move forward with the pregnancy medical home as one of our BDRs? Okay.
Do you need
I'm
a
seeing
motion
that.
to approve, or what do you?
We
is
do.
that-
We need a
Yeah,
motion to
I'll make a
approve.
motion to approve. This is Andrea, yeah.
Okay, is there a second?
Second, it's Marilyn.
Thank you. Okay, all in favor of moving the pregnancy medical home forward as one of our BDRs, say aye.
Aye.
I,
Aye. Anyone opposed? Hearing none, that's one of them. Great. Thank you guys so much. Okay, let's move to the second one, which is the perinatal quality collaborative. And we did have some edits that I believe
And I
maybe we'll
can-
have Dylan read back to us, yeah?
Yeah. So adding an implementation date, setting the expectation that they must meet at least quarterly, more specific requirements on the steering committee, a report to interim HHS, maintaining a data set, closed door session language to the extent necessary, and then subcommittee language.
Great. With those edits, would someone like to make a motion to move this
I can
forward
make a
as one of our?
motion. And so I can make a motion on that too. This is Andrea.
Thank you. Is there a second?
I'll second it. It's Marilyn.
Thank you. Okay, all in favor of moving the perinatal quality collaborative forward with the edits as Dylan read back to us, please say aye.
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 Anyone opposed? Hearing none, that will be our second BDR moving forward. Thank you. And then are we good with what was proposed in terms of bringing the third and fourth back for future review with some modifications related to the wider language and the like? Everybody is good with that? Okay. Do we need a formal thing on that, Dylan or Gabe, or?
I think as the chair, you control the agenda, and if you want to table those items for later discussion, you're perfectly able to do that.
Okay, so I'm gonna do that. I'm gonna table those for our next meeting with some more information brought back. Awesome. I think we did that, yeah. So now, now we'll move to agenda item 6, which is really to talk about our formal recommendations and the annual report. And so Dylan, you want to walk us through what you have on that? Oh, you're on mute.
We just wanted to provide an opportunity to discuss any formal recommendations that commissioners would like to consider at this time. Just to be clear too, this won't be the only opportunity. The meetings throughout the rest of 2026 will be dedicated to better understanding those non-BDR, non-legislative recommendations. This is just intended for inclusion ahead of the report due on July 1st. So one of the things that we have talked a lot about, and I include as an opportunity, is unbundling. Several commissioners have had significant interest in advancing this. So that antenatal labor delivery postpartum care services are reimbursed consistent with the AMA's coding changes. intended to better reflect how perinatal care is delivered today. I'd like to open the floor to discussion and possible action on this item to be included in the PPC's semi-annual report as a formal recommendation.
Marilyn.
May I ask a question? So I know that we don't really, the staff, you, Dylan, and HHS, all of them, they don't really have the ability to go to the legislators, but is this a report that, I thought the intent of the reports last time was to get them to the legislators, get them out front so that people could start thinking about it and look at ideas as opposed to making us work harder. Is this going to go to the interim health committee? Is it just going to be something that legislators get on first day, or what's the plan with it?
This recommendation specifically?
No, the report as a whole, because I just want to note that I think there's got to be context for folks in the report behind it.
Yeah, so the report is submitted July 1st and January 1st to the legislature, the governor, the Nevada Health Authority, and the Division of Human Services, and contains what we've been, I don't have the statute right in front of me, but the things that we've discussed in our meetings and any recommendations to solve any healthcare problems that we might have identified.
So on this one in particular, if you're gonna put it in the report, I would hope that you would put a lot of context behind it.
Yes.
Because unbundling all by itself is confusing for many.
Yep.
So I would put a lot of context behind it.
Yep. And this would be a programmatic recommendation directed to the health authority.
Again, because I think there's not legislative action needed to actually do the unbundling. Is that accurate?
Correct.
Yeah.
I think ACOG in the last meeting had also kind of acknowledged some of just ensuring that there was support through that process. That might be confusing if I remember correctly. I am supportive of putting this as a formal recommendation on my end. This is Andrea.
Yes, Adam, I would second.
Perfect. So I think we can do a formal motion. So Dr. Peterson, was that a formal motion?
Yeah, that can be a formal motion.
Okay, and then Adam, that was the second. I'm taking that as a second.
Yes.
Okay, thank you. All in favor of including this in our report, say aye.
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 Anyone opposed? Okay, so yes, please, Dylan, let's include unbundling. That would be great. And agreed with Marilyn's comments that, you know, helping to provide context in there and.
Yeah,
deeper
we'll add
understanding.
narrative as to
Yeah.
why.
Yep, thank you.
Oh,
go ahead.
sorry. I was just gonna say, are there any other additional formal recommendations commissioners would like to consider at this time, understanding there will be more opportunities down the line?
I think we've had discussion a little around, and this is Andrea again, around the NICU leveling. So I don't know if that's another very big topic, but that was another area that we had discussed in the past.
Do you have more specifics on things that you would be looking for in that?
I think Dylan, we've kind of had discussion. I think do you want to maybe elaborate on some of that?
Yeah, and I think there's more discussion that needs to happen at the commission level to kind of make sure that everyone's aligned on what those things are.
Do you want Dr. Peterson for us to work that up as a topic potentially for our next agenda or one of the next agendas?
I think that would be helpful.
Yeah, I guess the next piece is that staff and the chair are working to develop a work plan for the PPC's remaining meetings. So if commissioners have any thoughts of topics to consider in developing those future meetings.
Marilyn?
Thanks. Can I just ask that in a future meeting, so we're getting closer to the deadline, that maybe we outside of this talk about where we're headed as Medicaid as a whole, as the big beautiful bill takes effect, as the licensure pieces, I mean, to kind of get an idea of what everybody is seeing or thinking so we can prepare ourselves a little bit. I mean, we're nervous as counties on what this change looks like, right? At the same time, but I don't know that everybody is communicating. So it would be good if everybody kind of knows. So maybe Allison, you could give us an update on maybe what you're seeing on the federal level, the state level, and the county level, so that we kind of can prepare. Because I worry that we can do all this great legislation, but if there's no money, we can do nothing, right? So maybe we just, everybody needs to know what's going on.
I will point out there was a hearing, I believe it was with interim HHS on the impacts of HR1 or an update on HR1. So I can send the link along to that meeting as well.
That would be great. Sort of stepping back to other formal recommendations in terms of what we put in our report. Certainly, we've had a ton of dialogue around rural health for maternity care and the like. And I'm just wondering, are there any things, because I know that this is also an opportunity for the Rural Transformation Fund, where we might be able to put in recommendations to that group to explore or look for opportunities to help support specifically maternal child health. So any thoughts on that, you guys? Marilyn?
Sorry, I feel so talkative today. I don't
No, I
mean to,
love
but
it.
I love the legislative process. So, but so can I ask this? So maybe it makes sense for because I believe that they're in the middle of accepting all of these, looking at all of these applications. Maybe it makes sense for them to come before us to tell us kind of what direction, and then we could show them our stuff, they show us their stuff, and maybe some included, because I feel like everything that I've been part of on the NACO level has been so duplicative that people didn't know what each other was doing. So I think it would be great to hear kind of what they're even seeing, and then offer up some other ideas. Here's what we're thinking, kind of a real roundtable discussion.
I like that. It's a great idea. Any other formal recommendation areas that we want to explore? Again, we may not have a fully formed perspective on something yet, but if there's areas that we want to pull forward or go a little deeper on, we can do that as well, I think, in the next couple of. Okay, not hearing others, but I think we did capture a few of those agenda items for the work plan.
Chair Sexton, can I ask a question on that?
Yeah.
So are we confining those recommendations to maternal child health, or is there a broader scope?
The scope at this time is within perinatal health.
Thank you.
Okay, not hearing any others and seeing no hands raised. Dylan, you have what you need for now?
Yeah.
Okay. Okay. And I don't think we need any other approvals on that. That was just the unbundling one, right? Yeah. Okay. Let's see. So do you want to jump into this? I don't know. Are we going to do a formal approval today?
Yeah, it's due, but you can do it as amended.
Gotcha. Okay. So for action item number 7, the semi-annual PPC report was distributed to the commissioners prior to today's meeting for review. And we've talked a lot about that. We had the formal recommendation for the unbundling to be included in that and edited. And then I just want to make sure any last comments, edits, or other things that we need to bring up related to the report. Okay, and if there are not any more questions or concerns, then I will take a motion to approve it as amended.
Is Dr. Walker so moved?
Is there a second?
I can second that. This is Andrea.
Thank you. All in favor of approving, say aye.
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 Aye. And anyone opposed? All right, excellent. Thank you. And I think that brings us to the end of the formal agenda for discussion items, and now we have public comment.
Yep, this item on the agenda offers an opportunity for public comment. No action may be taken upon a matter raised under the public comment period unless the matter itself has been specifically included on an agenda as an action item. To provide public comment telephonically, you may join the meeting by dialing 775-321-6111, and when prompted to provide the meeting ID, enter 981-401-478#. Please press *5 to raise your hand during the public comment periods to provide your comments. Comments will be limited to 3 minutes per person. Persons wishing to make public comment will begin to be asked by stating their name for the record and spelling their last name. If you wish to provide public comment and joining by phone, please press *5 to raise your hand. If joining by the computer, use the raised hand icon at the top of the screen. Chair, I see no one wishing to make public comment at this time.
Okay, thank you. That will bring us to the end of the meeting. Thanks everybody for attending the public meeting of the Nevada Patient Protection Commission, and we are adjourned. Appreciate the great dialogue today. That was awesome.
And please be on the lookout if there is a meeting that is scheduled to talk about items 3 and 4 for BDRs.
Perfect. Yeah, and that'll be posted as usual to the website and all the things. So great. Thank you. Have a good day.
Thank you.
Thank you.